right?
Yeah.
And 1, go. What's going on, everyone? How are you today? I'm here with a good buddy of mine, Dr. Fred DiDomenico. And I just asked him to join us last minute. I was going to do this Facebook Live, talking about something he helped me with yesterday. Long and short of it, we have a physician's assistant who told one of my patients to quit care after 8 visits. And the guy has a massive loss of lumbar curve and low back pain. And we're going to go through the process. But what happened is Dr. Fred and I have been friends for a long time, since 2012. I coach with Dr. Fred on communication stuff. So a lot of the stuff that I have in my brain is habits and things that were formed from learning from Dr. Fred. Dr. Fred and I were talking about something yesterday right before I was going to reach out and call this guy. It wasn't really premeditated that I was going to drill Fred for format of how I should approach it. But I'm like, hey, I got the best communication guy in the world on the phone. Let's talk to him and see what happens. So he gave me a formula or some guidance of what to do. And truth be told, it's different than how I would have approached it. And it was better than how I would have approached it. And it went pretty well, but it kind of ended up in such a way where, it still ended up with that guy not wanting to admit that there was anything he didn't know, or, but anyway, I have those notes in front of me, Dr. Fred, but I think since you,
hey, let me comment.
Yeah, comment.
Well, I always tease you, Todd, because, you think out of the box, obviously, and I always tease you and say you don't play well with others because the first, and that's why you created something amazing, right? Because you're an innovator and you see the world differently and you don't fit into other boxes, which is also probably why it's a good thing that you called me, because when you want to have influence with people, you have to invite them into the process. And probably innately, you knew you might not be so inviting right out of the gate.
Right.
And so really the thing is, and this is no different with a patient. If someone does something that is opposite of what you want, or they say, I can't afford it, I don't have time, whatever it is, it doesn't really matter what the objection is, because the objection comes down to a belief system. And if you don't know what the belief system is, you have to know what the real objection is. Otherwise, you're chasing things around and you never get to the cause, right? It's like trying to pull a weed out of the ground by pulling all the leaves out. The leaves off the weed. You just got to get down there to the bottom and freaking pull it out by the roots, right? You got to know the roots, or it's always going to be there.
Right. So
anyway, we gave you a nice. What's that?
Yeah. So basically we talked and we went through a little format. I took some notes on it and I figured I'd share that with everyone out there, because there's a lot of doctors out there that maybe want to reach out to primary care physicians, medical providers, whether they want to reach out just to be nice and nothing bad happen to elicit that whole reaching out process. Or you have someone that said something that was like in conflict of what you told a patient, and now you're reaching out and you're not going, hey buddy, I'm calling because you just told someone something. What the F? Obviously that's not how you're approaching it. So the whole process of what you told me yesterday, and it's funny, like when I just called you and said, hey, you want to jump on a Facebook Live? You're like, well, I hope I can remember what I told you yesterday. I said, don't worry, I took notes. So that process, I'll start going through it, and I'm sure it'll come right back to you. But basically, he was calling him and saying, yeah, hi doctor, this is so and so. I'm calling you because I'm treating one of your patients, and it came to my attention that. So immediately acknowledging it's their patient that I'm treating, and not say like you're treating my patient. I picked up on that. I think you intentionally said it like that yesterday, right?
Yeah, because otherwise you're going to poke on their ego and immediately you break rapport.
Right. And so then from there, I said something to the extent of, hey, I know that you mean the best with your patients. But apparently you asked him to stop care. And I understand your concern. I just want to better understand your experience with chiropractors, or your experience with chiropractic.
Right. So with that question, you're getting right down to what's the core, because he may have a belief system about chiropractic, right? And you can't change beliefs with information. So who knows? Hey, there's almost an infinite amount of possibilities what his belief system is. So you have to have the reference point. So that's why we started with that question. And then what did he say?
And so then from there, he said, well, and he was like super nerdy, smart dude. He's like, well, chiropractors take a joint, past the normal range of motion, and a physical therapy approach is more of working with a joint within a normal range of motion. And so that's why, because this patient has pain and he had a little bit of pain that increased after his treatment, that's why I'm recommending that he does physical therapy.
And then we gave you, because we knew you would find the objection, right? And obviously he's got a very limited perspective of chiropractic. So then the next thing is you got to show why you're different.
Yep.
Without giving too many facts, right? Without teaching a workshop on why you're different, but you have to make short statements that make impact and present it in a way where he'll say, I didn't know that.
Right. Or they won't admit they didn't know that because they got too big of an ego, and that's what happened in this case. But I made sure at that point, once I knew it wasn't going to go in that like hold hands and sing Kumbaya type of direction, I just decided, okay, it's my job now to be able to like nicely point out that he doesn't know as much as he does, so that when he gets off the phone, he has a little bit of frustration of going like, man, that stuff I'm really not familiar with. Maybe I shouldn't be making these recommendations because I'm not an expert. And this guy I just talked to definitely knows a lot more than I do. Even though he's not going to admit that.
Well, the whole point is to get him to take responsibility. That's the whole point, because you can't make him power change till they take responsibility. So continue with how your next question.
He didn't take responsibility on this.
No, but that's the thing, right? Was to get him to a fork in the road where he's either going to go with his ego, but he is going to admit he doesn't know what you do,
right?
Or he's going to do the right thing,
right? And so then So then what happened from there? I said, okay, hey, totally understand that, and there's a lot of things that you said that are very valid. However, are you familiar with a technique called chiropractic biophysics and functional movement? Have you ever heard of that before? And he said, no, I'm not really sure. And I said, well, chiropractic biophysics happens to be the most evidence-based research method of spinal correction, not just within the chiropractic profession, but anything outside of the non-surgical realm. So it's pretty significant. That's actually something that we do. And then functional movement pretty much encompasses most everything that would apply to what you think of as physical therapy. So a second ago, you said that you're recommending them to do physical therapy. Totally understand that. Exercise, very important. However, something also that I learned is that you then repeated and took another x-ray of this patient. And he said, yes, we did. We took an x-ray. And I said, okay, so then I'm sure that you saw this patient has a huge reduction in his normal lumbar curve. He has a massive hypolordosis. And then his response was, well, I'm not really looking at that. I'm looking more at just what's going on with the joint.
Yeah, let me interrupt. So here's where this was very specific, because we said, what you're going to do is you're going to speak the best into them, because a know-it-all, they won't say they don't know anything.
Mm-hmm.
And somebody who's ego-based, right, say, well, then, as you know, then you must have saw the hypolordosis. Of course, they didn't. That's not the point.
Right.
And then you know what the meaning of that is with disability and chronic pain and leads to blown discs. And I'm sure you know that already, and you probably saw that on x-ray. Now, what are you getting him to say? If he says yes, then he hangs himself. So, and this is what I said to you, Todd. It's like you give somebody a rope, and they're either going to make a pretty little bow or they're going to make a noose. And in this case, it was a bit of a noose, right? So,
right. And so then from that point, he said something like, well, I'm very skeptical about anything as it relates to back pain, and I don't really trust anything out there. He said that. And I said, so you're saying that being a medical provider, you're saying that you don't trust peer-reviewed published research? And I said that and clinical results that have been demonstrated for decades. And so he was just, and then at that point, he stopped acknowledging my questions. He stopped, and so from there, we talked a little bit more. He basically said something to the extent of, it's the end of the day. I've seen patients all day long. I was not prepared that this is the way this conversation, that this is going to be this kind of conversation. It's making my head hurt. He said something like that. And,
what he's doing is bruising his ego. That's why his head hurts, right?
Yeah.
Because he's learning what he doesn't know. So let me say something real quick.
Yep.
And that, what Todd did is you're showing him what he doesn't know, and you're doing it in question form that it makes him look in the mirror. And that's the responsibility part. And this is like with any patient. If you notice what Todd did, he didn't make statements. What he did is he turned those statements into questions. And that's the difference. So that way they have to take responsibility, and that's how you handle objections. And these are all the things that we go over in the online coaching part that you and I just created, right?
Right. Yep.
Is got to ask influential questions.
Yep. And side note, that's something else, everyone. A lot of you are not aware. There's a whole section inside of Move Now University. I know we're doing this on our global group right now, or page. So there's a lot of non-members that follow us, but inside our program, there's a whole thing for elite. Dr. Fred flew out here about a month ago. We filmed a whole bunch of stuff. He flew out here a couple of weeks ago for our impact event. That was awesome. He's flying out here again in like 3 weeks because we're going through day 1 through day 5 in detail. But anyway, there's a whole bunch of notes I have on this, and it was more of a structure. It's not memorizing a script, but it's a thought process. It's a thought process.
And thought.
Yeah. And
it really is a mindset too. Those mindset masters. So what it is when you want to influence people, they have to take responsibility. If you want them to take empowered action, they have to take responsibility. And it's the sequence of questions that just allows them to look at the mirror. And then you're going to see, now this guy, he didn't like the mirror, right? That's right. Oh, my head hurts. And he said something like, well, it's the end of the day. I can't even think right now, which Todd and I were laughing. Well, and I have patients waiting. Well, you might want to start thinking if you have patients waiting.
Right.
Totally. Like a really brutal question would have been, well, were you not thinking when you made that recommendation? I wonder if that appointment was at the end of the day. Is this a common thought? Common yeah. That would have been funny.
Yeah, that would have been funny. Yeah. And then on the complete flip side, ironically, 2 minutes before we get on this call, I reached out to another patient of mine's doctor, a pediatrician. It's a young girl, 5-year-old with scoliosis. Doctor said something in passing, hey, it's not a good idea to get a whole bunch of x-rays. I don't disagree with that. However, if the x-rays have a very specific goal in mind and it's going to be helpful for her health, then it's very important. So I reached out to him, spoke with him. Conversation went completely different because of the way that he responded and the kind of person he was. And so now he and I have a lunch meeting in 2 weeks. He's coming by our clinic for a tour, and he was thanking me for reaching out to him, and it was the same kind of style of how I talk with him. Granted, first guy told my patient to stop care. This one just made a combat x-ray, which I didn't even address the thing about x-ray because at this point, it's not even needed because I spoke with him and he was so impressed upon how we're looking at things for her because I explained that up front. He said, I totally agree with that approach. I think that's great. So anyway, it shows there's that dichotomy between different providers. It's not that it's chiropractors against medical providers. It's chiropractors standing up for what's right, but not doing it in a confrontational way, but not letting people slide, I think, when they say or do those kind of things. Because it's like, right?
I mean, really what this is about is how you invite people into the opportunity to take responsibility on a higher level. And, this is, when you run it, I can't afford it. I don't have time. What's my insurance? All these things are the same way. I mean, we have it all in the system. Number one, how you can take them through a process, day 1 and day 2 to day 5, to number 1, eliminate those objections so you don't even have to listen to them. But if you do get them, how do you handle them, change their mindset, and pull that inspiration out to make them want to be in your program and make it a lifestyle?
Yep. And the thing that makes me think of is that patients who go through our process, because the way that we deal with them, are not used to anyone ever talking to them like that ever. Being transparent and being caring and connecting with them. And on the same note, a lot of people are not used to other people talking to them like that. So like this guy who I called yesterday, he's probably never had another provider call him and speak with him in that manner, And so he didn't even know what to.
Yeah.
So he just shut down. But anyway, I know you got to get on a coaching call.
There we go. Another adventure. Yeah, I got to get on a coaching call. So you guys are continue.
Yeah. So jump on the coaching call. I'll take you off here, and then I'm going to show some stuff on my screen. Thanks for joining me, though. Appreciate it.
All right, cool. Hey, my pleasure. Love you guys.
All right. See you. Bye.
Take care.
All right. Put my glasses on so I can see here. So something that I did, I'm going to show my screen over here. And let me just make sure that, okay, good. All right. So let me show you on my screen. Are you ready? Share my screen. How do I share my screen? Show. There we go. Like that. Flip this around. Let's do it the other way. Okay, cool. So from a science standpoint, okay, because here's what I'm going to do after this. I'm going to have my physician liaison, Kate, who goes out to attorneys and doctors and helps us build relationships. She's going to drop off some stuff to this doctor. So it didn't end on a bad note. It wasn't like, this. I ended with the guy and I said, hey, listen, I know you're busy. I know you got a couple patients still to see. And at the end of the day, it's not about you're right, I'm right, anything like that. It's about the patient. And right now, this guy has a severe hypolordosis. We were addressing improving the curve in his lower back, which is going to be important for his long-term health outcomes, because like I just explained, a decreased curve in so many cases explains why discs and joints break down, the thing that you said that you were concerned with. Back up a second. The cause is that reduced lumbar curve, improper functional movement, which we measured and we were addressing, and specific chiropractic care. He had the best of all three worlds. And when you told him to stop care and just go to PT, now he's doing 33% of what he could have done. And unfortunately, he'll probably get 33% of the result. Now, in this case, this guy's spouse was very pessimistic on the whole process, very unique individual. I'm sure that you met her. Maybe those were things that you saw, maybe not. However, by you giving that recommendation, that was the cherry on top that made it very easy for them to quit care. So at this point, my question is, knowing what you know now, what do you think can be done to salvage this situation? That's what I asked him. And he said, well, I don't really think anything can. I think they have their mindset and all this. And so then I just said, okay, listen, how about sometime soon in the future, I'll throw this invitation out there. I'd love for you to come by our clinic for us to meet in person. I'll take you out to lunch even, just so I can show you a little bit about what we do that is so different. So you can have confidence that when you have patients in the future that have these sort of issues, you know that they're being handled at the highest level of care. And he said, well, I can look into some stuff and all this. And so anyway, he was getting off the phone, got off the phone. Something we're going to do on this page over here, I looked up some different studies. Okay. And there's a couple things, I'm going to put this together for him. And some of it's just PubMed, but for you chiropractors out there, if someone has a reduced lumbar curve, this guy had a 0-degree lumbar curve and his sagittal balance was messed up. C1 was way over sacrum. Okay. He was not in that position because he was acute either. He was chronically in that position. The guy's in his late 50s. He reports he feels like he had that posture ever since, he was a child or something. And so that's something that really has to be addressed if this guy wants to actually get things fixed long term. Let me pull this off of here. Okay, cool. All right. So this guy needs to improve his lumbar curve. There's no other way about it. Are there exercises he needs to do? Yes. But he needs to do extension traction. He was doing home care extension traction. He was bragging about how he was doing it 4 times per day. He was doing better with care. And then he had one visit where his left deep hip external rotators, so deep, like glomerulis and all those were just tight. Okay. Guy has 0 glute activation, has severe glute atrophy. So from a functional standpoint, he needs glute activation like crazy. So that's what we're working on. His 5th lumbar is in bad shape. So we've set his 5th lumbar very specifically. That's helped him a ton. His left pelvis has been adjusted. That's helped him. Extension traction has helped him. So all of those little things. And he's been warned that, as you go through this process, things are going to flare up. Things are going to change. As we change that drastic alignment of your spine, do you think muscles are going at their attachment sites are going to be under different levels of load? Yes. So can you see why you can expect to have some soreness and maybe even pain in different places, at least in a temporary period of time as we go through this corrective process. Yes. So he understood that. His spouse, unfortunately, who was just extremely negative. She was there for the first 3 visits, very negative. Haven't met someone quite like this in a long time. He, on the flip side, very positive. Interesting mismatch here. But anyway, on this, causes of sagittal spinal imbalance and assessment of the extent of needed correction. So this is talking about, surgical intervention to take someone from a massive loss of lumbar curve and how they go through multiple level osteotomies. So they actually cut out the bone at the posterior. They cut the interlongitudinal ligament, cut the front of the disc to create extension, because they find that creating that curve and improving sagittal balance is that important for long-term health outcomes. Now, we're not proposing to do it like this, but unfortunately, that's what this guy is going to be up against in the future after he goes to like basic physical therapy, which is done in-house from this PA was referring internally to a hospital system that he's part of, wants to keep it all in-house. They'll do some generic pain relieving physical therapy. This guy's not going to get any long-term functional rehab. He's not going to get curve correction. He's not going to get specific segmental adjusting. It's a bummer. Okay. So there's one. Second one, correction of kyphotic fixed lumbar segments and hypolordosis with the transforaminal lumbar interbody fusion technique. Why am I going to include this study? Because I'm going to show in the peer-reviewed surgical literature, this is a very important thing that they do surgically. We do this non-surgically, and I feel that he was going to respond quite well to this to avoid something like this in the future. Increasing of cervical and lumbar lordosis is possible despite overt osteoarthritis and spinal stenosis using extension traction to relieve low back pain, leg pain. So this is a case report, chiropractic biophysics case report, find on PubMed. And then let's see some other stuff that we look at. Okay, some other little articles is just so this guy understands that we know what we're doing. A great resource, Brookbush Institute, great resource for functional anatomy. This is what we use as our encyclopedia. So there's some different articles. He cites research in multiple articles. I don't think these are the articles. It's not loading fast enough here, but at the bottom, it has all the citations as far as functional anatomy, why like in these cases where you have overactive deep hip external rotators, it's because ultimately you have inhibition of glute max, weakness of glute max, usually weakness of glute medius as well, why those need to be strengthened, activated. And then I also pulled up a couple other things. Okay. I pulled up some of this stuff. This is CBP research. Okay. Program of care derived from pain data reported in RCTs, so randomized clinical control trials on low back pain. And the conclusion, data from RCTs did not support claims of restricting chiropractic care to 6 to 12 visits only. In fact, assuming a constant linear dosage response curve in studies with chiropractors as the treating doctors, it was estimated that 28 visits were needed to document, resolve, and stabilize this condition. This guy was 8 visits in, showing that in 8 visits, even though he's showing positive response and he had his first exacerbation, that's not uncommon. That doesn't mean you cut care. This right here was a summary of how many randomized clinical control trials they looked at. Where was it? 65. So 65 RCTs out there they looked at, and they all came to this conclusion. So that's pretty compelling. This right here, changes in sagittal lumbar configuration with new method of extension traction. So this is not a study necessarily, but a publication talking about this. This is the type of extension traction he was doing in his lower back. And then if this guy wants to question what is a normal lumbar curve, I threw this one in there, elliptical modeling of sagittal lumbar lordosis and segmental rotation angles is method discriminated between normal and low back pain subjects. So that's basically showing that you can predict pain based on curvature in the spine. Okay, so this is a study that was published in Journal of Spinal Disorders in 1998. Let's see, what else do I have pulled up here? I think those are the main studies I pulled up. Okay, so this is what we're going to put together and we're going to bring over, and really, that conversation went a little bit, like it was pretty predictable. That's pretty much how I thought it was going to go. But the difference is this. The difference is, and I talked about this a few minutes ago when Fred was on here too, is I just spoke with a pediatrician on the phone who had who made some kind of comment where the parent was concerned about a repeat X-ray. 5-year-old daughter, pretty significant scoliosis, and at 5 years old, you definitely want to watch that closely. And all the scoliosis training, the best place to learn that, go to a CBP seminar, go to their scoliosis and advanced scoliosis. You'll learn more there than probably 99% of all the stuff out there on scoliosis. And anyway, 5 years old scoliosis, you definitely want to be monitoring that closely because it can progress like that. And so having periodic X-ray is very much warranted. And the whole process of follow-up that we were going to follow with her, I think, was well within very conservative care recommendations. So I just reached out. I didn't even address the X-ray thing. I just called, told him an update on the patient. He was already super positive from the get-go. And it resulted in, like I said, we're going to be meeting up in person. He's going to come over to the clinic. We're going to meet him in person. Sounds like a great practitioner, really cares about his patients. And that's at the forefront, is he's thinking, oh, that's great. This other practitioner reached out to me and wanted to talk about this patient. Just like if someone reached out to me and wanted to talk about a patient, I'd be all ears. I would talk with them. And as much as I'm very confident in what I do, and maybe sometimes in the Facebook lives, you see like, I bet you would be button heads with everyone if they called you. That's really not how I approach that. Is I'm very respectful. And I would say, hey, thank you so much for taking the time to call and reach out about John Smith. It's obvious that you really care about your patients. Okay. Making a statement like that and then immediately having them go down a little bit. And then you can just talk person to person. Here's my expertise. I know you have your expertise. Let's just share about our two different perspectives so we can ultimately help our patient at the end of the day. It's not about you or me being right or wrong. It's about this patient has a certain problem. You and I both have a certain level of expertise. Let's talk about it. Let's see how we can put our heads together to help this patient get the best outcomes possible. How's that sound? Right? So anyway, that's what I wanted to share. If you want to see more about our program on the functional movement stuff and functional rehab and how we put all this stuff together and why we have, over 140 doctors around the world that follow our systems and have access to our systems, and we've known for the last several years, check out our demo. Go to demo.movenowyou.com. Check that out. And you can always reach out to me on Facebook and message me if you have any questions. Hope you have an awesome day. Hope you got some good pointers from what we talked about here as far as how to reach out to other medical professionals, how to bridge the gap, how to work as a team, how to know how it's going to work when you got someone that's a little more confrontational. And thanks to Dr. Fred for jumping on here and helping out. He's always a great resource for communication. And if you want any information about Dr. Fred as well, reach out to me. I can connect you guys as well. So anyway, with that said, thank you. Over and out. Talk soon.